Dr. Sherilyn Smith is Associate Professor of Pediatrics at the UW School of Medicine, in particular Children's Hospital and Regional Medical Center. She's a member of the Clinical Infectious Disease Service and attending physician in the infectious disease clinics out of Children's Hospital, the consult service, and the general pediatric service. And she provides diagnostic and therapeutic services for children with proven or suspected infectious diseases and treats complicated chronic and or recurrent infections. I've had the pleasure of knowing Sherilyn for over 5 years now, and she was instrumental in the design and implementation of the new college system within the University of Washington School of Medicine that emphasizes clinical teaching at the bedside and role modeling in issues such as patient care and professionalism. She's the head of Big Sky College, and she's also Associate Pediatric Clerkship Director. She's also a preceptor and leader in the Students in the City, which is a community student-run clinic out of the Aloha Inn, which is a transitional housing facility for the homeless in King County. Dr. Smith received her MD from Baylor College of Medicine in Houston, Texas, residency at the University of California, San Diego, and fellowship at the University of Washington. And in 2005, she received the Margaret S. Anderson Award as well as an Outstanding Clinical Teacher Award. And the Margaret S. Anderson Award is voted on by the graduating medical students of the University of Washington for that clinician teacher who has amazing support and concern for the training of medical students. So without further ado, you guys, would you please welcome to the stage Dr. Smith.
Hey, well, I want to thank you guys. I'd like to talk about a story and start with this. And this is a story of the patient, one of the very first patients I saw when I was an intern in pediatrics. And I was a bit naive. I was from Texas. I moved to California, and I was introduced to this child. And she was 2 months old, a previously healthy girl, and she developed a little bit of a cold, and her mother got increasingly worried because she kept having more of a cough and couldn't eat and seemed sicker and sicker and sicker. And she brought her into the hospital, and she was admitted the night before I began my internship, and she was there for an entire month. And one of the things that struck me was, in my naive way, how could this be? Because she had a vaccine-preventable disease, and I thought, heck, I've been immunized. How could this happen? And so I'm going to come back to the story and really work through some of the issues on a personal level to try to demonstrate how science, public health, providers, and patients come together really to protect the public health in a coordinated manner. And so these are the things that I'm going to talk about tonight. A little bit about the history of immunizations. I think it's important to remember where we came from. What happens in the body when you immunize, to give you a little bit of a framework for some of the things I'll talk about in the end. Work through a case study of a common disease and how immunizations impact that. And finally, facing some of the concerns people have now in the 21st century about immunizations. So immunizations have not been around for a long time. In 1721, that's really when the first immunization started, and it's something called variolization. This was a purposeful inoculation of a small amount of smallpox, really to prevent that disease. And this was done by Lady Montagu in Britain and Cotton Mather in New England, and it became widespread practice. However, this was not a great vaccine. There was a 1% mortality associated with the vaccine, but it was a heck of a lot better than getting the disease, which had a 40% mortality. And so this was widespread, and there was this kid who was variolated when he was 13 years old and went on to improve the status of this vaccine. And so those improvements that happened about 75 years after the institution of variolization were by Edward Jenner. And he was a great physician and scientist, and he was a wonderful observer. And so he noticed that milkmaids who would get an infection called cowpox that looked very similar to smallpox didn't get smallpox. Now, he was not the first person to notice this, but he took his observation and had an experiment. And I'm kind of glad I was not a kid living there around him at the time. So what he did was he took James Phipps, who was a 7-year-old boy, and he took some of the material from the cowpox lesions from these cows, and he inoculated James with this immunization, actually. And then he gave him the smallpox variolization, the slow dose amount of smallpox, to see what would happen. James did not get sick. Okay? Then he immunized him again. He gave him another dose of smallpox, and he didn't get sick. So Edward Jenner said, this looks really good. He didn't get sick. He didn't die. I'm sure James was really happy about that. And then Jenner expanded this and immunized 23 more people, including his own son, and said, this is a good vaccine. This is actually something that's better than the current standard. So he tried to present his findings to the wider scientific community, and he was not well received. He was made fun of. They said it was impossible. This was too revolutionary. And it may have come from the fact that this was a material from a lesser animal that somehow could protect human beings. That's sort of the way people were thinking then. But it really didn't matter because the results were great. People found out about this, and Edward Jenner made a lot of money. And a lot of people came to him and said, I would like to have this vaccine. And so in addition to giving us the first really effective vaccine that was safe, he also gave us the word vaccine, which is derived from the Latin word cow, from cowpox and smallpox. So that's where that word comes from. So this is a listing of the vaccines that we actually give to kids now. It's a long list, and the kinds of illnesses that we protect against are both those really long-term cancer-preventing vaccines for hepatitis B and papillomavirus, but also some life-threatening diseases, things like tetanus, diphtheria, meningitis. So there's a wide range, both bacteria and viruses, that impact public health. As a pediatrician, I know a lot about immunizations because you will notice here, these poor kids, they get immunizations, a lot of them, in the first year of life. And this really represents one of the times that public policy and public health really come together for the betterment of children, because we know that parents bring their kids in for well child exams, so we target those vaccines in that captive audience. Okay? It's also because kids are a very vulnerable population, and much of the illness that we're trying to prevent occurs in this group. So it's both for the patient as well as the public good and some practicalities. So my son can't believe that he had to have so many immunizations. I couldn't believe it either. But I'd like to go back and show how effective these things are to help remind us all, because I think a lot of these diseases are gone and many people don't have a great appreciation of this. So measles, this is a viral disease. It used to cause about 500,000 cases a year up through the 1960s. Okay? 500 people a year died from this illness, so it's pretty severe. You can look at rubella, about 60,000 cases a year, much fewer. However, there's something called congenital rubella syndrome that we really wanted to prevent. And what that is, if the pregnant mother gets infected with rubella and the children is born with this infection, they have underdeveloped brains, they have mental disabilities, they have cataracts, they can't see, they have hearing loss, they can't hear, they have heart defects that may need surgery. So this is a devastating illness for the child and for the family, and we really wanted to protect kids and have this go away. Diphtheria, a very serious bacterial illness, somewhere between 100 and 200,000 cases a year. 10% of people who got this died. Polio, another viral infection, very widespread. And there were epidemics of the paralytic form, the very severe form, that occurred throughout the early part of this century. My mother tells stories of not being able to go to the pool, not being able to go out because people are worried about catching polio because they couldn't tell who was sick or not. Strep pneumoniae is a bacteria that can cause pneumonia. It can cause other types of severe illnesses, such as bacteria in your blood and meningitis. 500,000 cases a year, it was the estimate, and the highest rates actually occurred in young children. To give you an example about how common this is, for every 100,000 kids between the age of 1 and 2, 200 of them would get this type of infection. So very high, and as a pediatrician, I saw a lot of kids with this. Haemophilus influenza, fewer cases, but again, very severe meningitis, bacteria in the blood, other severe infections, primarily in children less than 5. What about now? So remember the 500,000 cases of measles? In 2004, there were 37 cases, okay? That's a banner year. That's a lot of measles cases. And you can see here that most of them were brought from outside of the United States by people who were not immunized. Rubella, during the same year, there were 10 cases of rubella. No congenital rubella. Diphtheria, eradicated. Polio, eradicated. Strep pneumoniae, a 60% decrease in the rates of infection in the most vulnerable patients, the young children. Haemophilus influenza, instead of 20,000 cases, 19. More than a 99% decrease in the number of cases. And I think a picture is worth 1,000 words. And look at this. So we could see the peaks of the outbreaks of measles, the introduction of the measles vaccine in the late 1960s, and then once we began to have more measles vaccine, you could see the rates going down. That peak in the late 1980s and early 1990s was when I was a resident and I actually saw kids with measles, and that was primarily because there were so few kids actually immunized in urban settings with the measles vaccine. Look at the inset and you can see what's happened since we sort of got that under control. There's almost no measles, and there are just few little outbreaks, and we've said that it's eradicated in the Americas. So a success story for immunizations. So I want to touch a little bit on what actually goes on in your body when you immunize, because I think that it helps you understand some of the concerns that people have about immunizations. So there are two big parts of the immune system, something that we call humoral immunity that really deals with protection against bacteria, and T-cell mediated immunity that deals with protection against viruses and fungi. For the humoral immunity, the main player, the white blood cell that's really in charge of this, is the B cell. It circulates in your blood, it's in your lymph nodes, it's in your spleen, and it interacts with parts of bacteria. That's what that squiggly orange line is supposed to be. The T cell is a much more complicated system, and that thing right in the middle with the DC, it's called an antigen presenting cell that takes up parts of the virus or the fungi, kind of goes through the machinery inside the cell, and then parts of it are presented or given to the other types of cell, the T cells, which then replicate and produce other types of proteins that really rev up the immune system and get those cells ready to go and fight off infection. So what are immunizations in a very broad principle? The human body must win the race against the microbe to survive. Okay? Immunizations give us a boost, okay? Give us a head start with that. And the players are the immune system that I mentioned, and then the parts of the vaccine. I'd like to go through about how we use science to understand the parts of the immune system to make better vaccines now than we have in the past. And it's, again, another intersection of science, public health, and then the patients. So again, there's that B cell interacting with parts of the bacteria, and the goal is to make immunoglobulins, those proteins that are in your body that glom onto bacteria and either help them get swept out of the body or killed by other parts of the immune system. And it's not just the B cell, they interact with other cells, and it's kind of cool, the different ways that the body has adapted to recognize pathogens. There's something called pathogen-associated molecular patterns, so things that are on bacteria that don't belong. No human body has them, and so our cells recognize those. Those antigen-presenting cells interact with the B cells. They turn on the plasma cell that's like a factory that makes lots and lots of immunoglobulins, and then it just sprays them out, and you're ready to go. You're ready to fight the infection. The problem with this is that kids don't do this very well. All right? So it's not until you're older than 2 years old that you can actually do this very efficiently. So we used science, not me, but other scientists did, and remember, the goal is to make lots of immunoglobulins. So what they did is they took advantage of those T cells that are out there that are much smarter than the B cells. They used the interaction between the T cell and the B cell to recognize a different part of the bacteria, to get things revved up faster and more efficiently, to turn those plasma cells on, and to make globs and globs of immunoglobulin, all right? So that's how scientists have figured out what are the parts of the immune system that are important, and how can we use parts of the bacteria or virus to make better vaccines. And the net result is that we're exposed to small amounts of the microbe. It induces immunity before infection, both antibodies and those T cells that are ready to fight off the pathogens. Sometimes we prevent infection, but most of the time we modify or prevent disease. And so what I'd like to do now is move on to a case study about how we can use what we know about pathogens, epidemiology, to really impact the wellness of people. So I'm coming back to that first case that I talked about, the baby that was in the hospital for a whole month. I actually saw a 14-year-old girl who came in, and she had lost 14 pounds in 2.5 weeks. And when I saw her, I thought, oh my gosh, she's got cancer. I wonder what's going on. And then I found out that she was having lots of vomiting. And then I found out that all the vomiting was after she was coughing. And then we recently saw a little boy, 11 months old, who came in again with lots of weight loss. He had a really high white blood cell count. I thought, oh my gosh, what's going on with him? I'm really worried about him. Maybe he's got cancer. I always think everybody has cancer when bad things are happening, I guess. And then I found out that he too was having repetitive emesis after coughing, and guess what? 3 other people in his family were coughing, and this happened in the last 6 months. All these people have whooping cough, all right? So this is the disease I thought was gone. It's a bacterial infection of the lungs. It's caused by the bacteria Bordetella pertussis. And if you look at it under the microscope, it's sort of a long, kind of skinny, roundish, squarish cocobacillus. That's what we call it. In the 1930s and 1940s, there were about 200,000 cases a year. The vaccine for this was introduced in the late 1940s. Unfortunately, unlike what happened with measles, in 2005, there were 25,000 cases of pertussis, and we've had the vaccine for almost 60 years. So remember that picture, that lovely picture of measles going down and going away? There's a different picture with pertussis. And you can see the introduction of the vaccine, a nice decline in the numbers, and then they started going back up. And if you look at the inset, you can see that the people who are getting the vaccine are older. Remember, we're immunizing all those poor little kids are getting those immunizations before they're 6. So what's going on here? I want to talk a little bit about the illness so you can hopefully not self-diagnose. There may be somebody here with pertussis or had pertussis. We'll find out. So the incubation time is between 5 and 10 days that you harbor the bacteria. You may or may not be very ill. It may be up to 3 weeks before you become symptomatic. And usually the illness is very slow onset. It looks like a bad cold. Okay. You have a runny nose. You may have a little bit of a cough, maybe a little bit of a fever. And then the cough starts. And there are 3 stages that are listed up there. The catarrhal is sort of the runny nose stage. And then we call the paroxysmal, and this is the coughing stage. And typically what you will hear in the classic description is cough, 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 cough. And that's the whoop, all right? The thing is that not everybody whoops. And so if you're listening for the whoop, you might miss it, okay? So the 14-year-old that I saw who had lost a whole bunch of weight, no whooping there. The baby, no whooping there. It's really a school-age kind of thing that occurs for that classic description. The Chinese call this illness the 100-day cough, to let you know how long the coughing goes on. And because there's so much damage in the lung from the infection, every time you get a cold after you've recovered from this illness, you may start coughing again. All right? So it's a very prolonged convalescence. And we don't worry just about the coughing and the vomiting, although that's pretty bad. We worry about the complications, much more severe in children, and that's one of the reasons that we immunize them. 63% of infants, children less than a year of age, who get this disease are hospitalized. A large proportion of them develop apnea or they stop breathing when they get this illness. And 13% of them develop pneumonia, usually from a bacterial superinfection or another bacteria that gets into their lungs. The disease is much less severe in adults. 5% get pneumonia, but an important thing for you all to know is that many adults with pertussis have very few symptoms, just a little bit of a cold, and that's it. So let's talk about pertussis immunization. I want you to remember that, sort of person walking around harboring pertussis in your brain. As I said, we introduced the vaccine in the late 1940s, and the kind of vaccine it was is a whole cell vaccine. So they took pertussis bacteria, they killed it, they ground it up, and they made a vaccine out of it. Very similar to what Edward Jenner did. It does induce immunity. You saw a nice decrease in the rates of pertussis. However, it's not lifelong immunity. So we know somewhere between 5 and 10 years after that immunization, you're no longer protected against the infection. All right? So that's why those adults are walking around with bacteria in their noses and coughing and infecting other people. The other problem with the vaccine is there were lots of side effects, very similar to variolization with smallpox. This was not a great vaccine. It was the best that we had. Side effects included high fevers, in some cases seizures, there was persistent crying, there was worry about encephalitis, lots of problems with this vaccine. So, like Edward Jenner, people in the 70s and early 80s developed a different kind of vaccine that had fewer side effects, about the same efficacy and protection, but it was an acellular, so just parts of the bacteria were used that we knew induced immunity. And that was introduced in the 1980s. However, as you saw in 2000 and beyond, we saw rises in the numbers of cases, and so we had to expand the number of people and the types of people who were getting this vaccine. We now had a vaccine that had fewer side effects, was very well tolerated, and so it's been introduced to adolescents and adults to help curb that big reservoir of people who may have disease and not know it. And think about the adult who has that mild case. They walk around coughing a little bit, and they can infect a child that's incompletely immunized. They can infect another adult that has had waning immunity, or they can infect someone who never had any immunizations. So there are many ways for this to be transmitted in the population. And so what's going to happen with this new strategy? We hope that we see fewer rates of, a smaller rate of pertussis infection. We hope that this expanded coverage will lead to fewer ill adults. It will help protect those incompletely immunized children, and it will decrease transmission within hospital settings, which does happen because we as healthcare providers have waning immunity, we're exposed to people who have tuberculosis, and we become sick and don't know it. And I've really talked about what happens here in Washington State and the United States, but you need to have a broader view. The only illness that's vaccine preventable that has been eradicated is smallpox. So you saw that long list of all the vaccines that we give. So it's very much a global world. There are problems with access and vaccine development, and both are barriers to getting widespread vaccine use throughout the world. To give you an idea, about 80% of kids have had 3 pertussis immunizations. That's 30 million kids who don't have access to the vaccine or are incompletely immunized. There were over 2,000 cases of polio, and there's 6 countries where polio is still endemic. So if you travel or people travel to the United States, it's possible that polio could be reintroduced. Maternal and neonatal tetanus is still a problem and is life-threatening in babies in 50 countries around the world. So I want to turn to another story to help illustrate some of the ongoing issues that we have here in Washington to end my part of the talk. And so this little boy I saw was 4 years old, previously healthy, and he came in with a high fever of 103 for 2 days. He was sick. He did not feel good. He had swollen lymph nodes in his neck. He had lots of cough. He had red eyes. He had a runny nose. He had measles. So I saw a fair amount of measles when I was a resident. And the reason he had no immunizations was that he lacked access. The concerns now usually are not due to access, but other concerns. Primarily, parents are worried about safety. Their immunizations really are quite safe, but people focus on those rare side effects that may or may not be actually linked to the immunizations. And I think that's a function of our technology. There's no perfect vaccine. People want a perfect vaccine. There is no such thing. And they actually want a perfect vaccine that is perfectly safe. And those don't exist. I don't think there's anything that's perfectly safe in the world. And there's also a perception that the diseases are gone, and so you don't need to immunize. And it's sort of taking advantage of the fact that there's a large group of people that are immunized in the United States, and that the disease prevalence is very low. But remember, we're in a sort of a global situation here. I want to touch on two specific controversies and let you have an insight. I understand these controversies, so I had a moment of psychosis myself when I had to have my son, he was going to receive his first immunizations, and I sat in the room and dreaded those 5 shots that were going to come in. He was like a little squirt, and I thought there for a moment, oh my gosh, what if the stories are true? And then I thought, you're nuts. You're an infectious disease doctor. What are you thinking? You know better. But in that moment, it completely resonated with me where the parental anxiety comes from. And I think I had that understanding right at that moment, even though I talked about this and talked to parents about this a lot. So I can understand, but then I think part of our job as care providers is to help people negotiate that fear. So sudden infant death, the unexpected death of children less than a year of age, was thought to be linked initially to the DTP, or the pertussis vaccine. And this was an unfortunate sort of correlation in time because most of the infant deaths occur when babies are less than 6 months. Most of the immunizations occur when babies were less than 6 months. And so people were concerned that there was some causal relationship. But we actually know now that another public health intervention, the Back to Sleep initiative, in which babies sleep on their backs instead of their stomachs, is actually one of the things that have stopped SIDS. And there are also studies showing that increased rates of pertussis vaccine are also correlated with decreasing rates of SIDS. So you have to work through the fear to get to the data and realize that there's no correlation. I think that the hot controversy right now is the worry that autism is somehow related to immunizations. And there are two sort of hot topics right now about this, and they're very different. One of them stems from the thought that it's the MMR, or measles, mumps, and rubella vaccine that is correlated with the increasing rates of autism. I think, again, it's one of those time correlation observations. Most kids with autism don't begin to show signs until they're about 15 or 18 months old. The immunization occurs at a year to 15 months of age. The initial data from which these worries were generated had nothing to do with the vaccine. And now the people who were involved, all but one, who were involved with those original studies have recanted the things that they said. And there have been large epidemiologic studies showing there's no correlation. However, we're still left with the fact that we don't know why the rates of autism are going up. Maybe a good topic for a future talk. Similarly, people worry about thimerosal, which is a type of mercury that's a preservative in immunizations, and there's worry that there's some correlation there because of the history of mercury poisoning leading to madness in the past. The signs and symptoms are different, the type of mercury is different, the levels are almost non-existent, but again, there's worry, and I think it really comes from the parental desire to do the best they can for their kids, and it's our job as providers to help people negotiate that. So to that end, the CDC has really helped providers have some talking points and understand what people are really worried about. So these are the top 6 reasons people don't want to have their kids immunized. The diseases have begun to disappear, and we sort of talked about that, and you've seen those graphs with precipitous decline once we started immunizing. The majority of people who get the diseases have been vaccinated. We know from the natural history of some of these diseases that for measles, say, the attack rate of somebody who is not immunized is 30 times higher than someone who has been immunized. So it's just not borne out by what we know about the diseases themselves. There are lots of vaccines that have been associated with more adverse effects. We also know that that's not true through our epidemiologic studies. Vaccines cause many harmful side effects. Most of them are local side effects. Again, this focus on these rare, unproven links. Vaccine-preventable diseases have been virtually eliminated from the United States. They have, but it's the world that we have to worry about now with global travel. And giving kids multiple vaccinations can overload the immune system. And if you all go out of this auditorium and take a deep breath, you will have had exposure to more things for your immune system than you would ever get through a vaccine. So actually that doesn't make sense either. But again, the immune system, I hated immunology when I was a medical student. It's a really hard thing to understand. And so really getting down to the details to figure out what's going on with the immune system and understanding what works is a challenge. So I wanted to show this. This map shows the rates of people opting out of vaccines in Washington state. The counties in red are that there are greater than 5% of the kids with saying no immunizations or limited immunizations. This is a very different picture than 5 years ago. All right? So this is a local phenomenon that you all need to be aware of. So the implications are that without immunizations, there'll be a resurgence of disease in the United States, in part due to global travel, in part importing diseases from different areas where it's still endemic. There's an increasing susceptible population that will facilitate transmission among the greater population. And an unintended side effect is there are many healthcare providers who don't have experience dealing with these infections. For example, meningitis used to be very common in childhood. You talk to most trainees right now in residency who are pediatricians, they've never seen it. And it's because we have vaccines that prevent it. That's a really great thing, but they don't know how to manage these diseases very well. So in summary, the immunizations have improved the lives of children throughout the world. Many still do not have access to the vaccines, and we need to work on that to improve everyone's health. There is a growing movement in the United States not to vaccinate, and the public health improvements through vaccines really show how science, public health, patients, and providers come together to improve our lives. And I want to thank Chris Wilson and Ed Marcuse for some of the slides, and the people not mentioned here, my husband for listening to my talks and doing the pictures that you have enjoyed, and my son for being the inspiration for caring for kids. So thanks very much, guys.
One of my jobs is to teach over at Harborview, and I teach at the bedside, and so I had some fourth-year medical students there today, and I had to leave a little bit early to get over here, and they asked me what I was going to be doing, and I said I'd be introducing Dr. Robertson, and they both lit up, and they said he was the best lecturer we had during medical school. We learned so much from him. So it's my pleasure to introduce Dr. Robertson. He's a professor at Pediatrics in the UW School of Medicine and medical director emeritus of the Washington Poison Center. He's a nationally recognized expert on poisoning, and this is an area that's very important to us as nephrologists too, because we often get called in at Harborview and elsewhere when people have poisonings. He's authored the sections on poisoning for the Merck Manual, which is one of our personal favorites, Cecil's, and Dreisbach's Handbook of Poisoning. Throughout his entire career, Dr. Robertson's been a vocal advocate for patient safety, poison prevention, and medical error reduction. His early work in the 60s highlighted the role of home management of poisoning to eliminate life-threatening delays for treatment. His recommendations eventually led to the widespread use of syrup of ipecac in medicine cabinets across the nation. In Washington State, he worked for years to support laws mandating the use of identification imprints on solid prescription medications and eventually over-the-counter drugs. In 2006, Dr. Robertson saw more than 20 years of advocacy come to fruition with the new anti-scribbling law, which went into effect June 7. He's a former coordinator of the UW Medicine Pediatric Clerkship Program, and he's the recipient of 4 UW Distinguished Teacher Awards from graduating medical student classes. The 1996 award designated him as a teacher superior in perpetuity. Dr. Robertson.
A few things I just mentioned that relate to history. And looking at the issue of chemicals down through history is important, and I'm going to show you a few slides about it. You've heard about infectious diseases, and as Sherilyn finished up, she mentioned about autism and its possible connection. Well, looking at the audience here, I needn't remind this audience, because you've read it in the press, that they're talking about ethyl mercury, thimerosal, that has been used as a preservative in immunizing agents since 1943. It's been taken out of all of the vaccines, save for some of the influenza vaccine, because there wasn't enough to go around. But the press continues to give equal time to the people who have concerns about mercury in the vaccines. And I just warn you a little bit, because I may sound anti to them as a group making a fuss with vaccines. I turn around and look at our state health department, and I have a problem with them too. Because all of you of the female gender who are in the procreation phase, and that's now judged somewhere between 8.5 and 9, and over 70, that'll make you all feel good. If you want to get your daughter's fertilized egg implanted in your uterus, you can carry it to term, and some women are doing this. I think to myself, that's one thing, if there's any question, if men were having babies, they would never do a thing like that. As a matter of fact, they'd never have any babies, and that'd be the end of the human race, because we're not going to go through that kind of a fuss. The health department is concerned that you can't eat tuna fish because it's going to give you some problems, not ethyl mercury, but methyl mercury in the fetus, making the child grow up either Democratic or Republican, whichever one you think is a problem. The evidence for that in the state of Washington is slim and nil. Fortunately, from the state of Washington, and here I'm being a little bit, well, not quite cynical, still skeptical. It's only Tuesday. Friday, I'm cynical. Skeptical, and that has to do with the issue, if the mercury were in the salmon, would we hear the same amount of noise that we do when it's in the tuna fish? The tuna fish are products of California. The salmon are products of Washington. Well, you don't hear about mercury in the salmon. You hear about PCBs in the salmon. And yes, PCBs are there. And a lot of different chemicals are out there that may have some bad consequences, but it's going to take some time before we find out. Lest you think that this is an easy matter, just a little bit of history. When Dr. Lind, on a sea ship traveling from over the Pacific, looked for the cures of scurvy back in the 1600s, he had a sample of 12 patients, and he divided it into 6 groups and fed 2 of them fruit. The others got some alcohol and some other things, and it didn't work on those 10, but it did on the 2. 200 years later, that observation helped defeat Napoleon. After the French fleet had chased the British fleet all the way over to South America and all the way back, with the British limeys taking fruits, not getting scurvy, and the French not adopting that technical advance, that scientific advance, and they lost at Trafalgar because so many of the French sailors were down with scurvy. Took 200 years for that bit of information to really get integrated because the British Maritime still hadn't adopted it when that occurred. Think of that, and then compare it with 25 years ago when Mike DeBakey did open heart surgery on TV. The next day the world knew about it. And think it's only a little bit, not too long ago, how long did it take for the British to find out that Lincoln had been killed? 2 weeks. 2 weeks. How long would it take to find out today? Instantaneous, and it's getting even shorter. I mention this because when it comes to chemicals, it's an interesting time to be alive, and I want to tell you some of the things that happened in my career that are going to impact you dealing with that matter. So let's go and we'll look at the first slide. When I got started in 1950, the American Chemical Society had a registry, and on that registry, they listed 1.2 million chemical entities. 1.2 million chemical entities since the origins of mankind. For those in the audience who took chemistry in school, just remember, no organic chemistry until the 1860s, not very long ago. And the dye industry was what brought it to fruition. By 1990, 13 million, and last February, it's up to 88 million chemical entities are described. Now, we're pretty good about the toxicity of one chemical taken one at a time in a genetically similar population, and preferably either all males or females, because of the XY story. When you talk about 50 chemicals being taken in combination by people of multiple genomes who are eating a widely variable diet and try and tease out with reasonable certainty the likelihood of something happening that occurs once in 10,000 times, it's not easy to do. I mention this because when you think about the poisons or the potential poisons that are out there, with 88 million chemicals out there, that's a lot. I'm pretty good on 3 or 4. Actually, I used to be pretty good on 3 or 4. Now I'm only good on about 2, because I have some senior moments and I'm not sure which one is which. Everybody in the audience will have an opportunity to have that happen, in multiple situations as time goes on. I'd call your attention to the fact that the Chinese were very important in looking at the history of toxicology in 2000 BC. The ancient India had texts in 1200 BC. The Greeks 650, and we had classified animal, vegetable, mineral, acute, and chronic shortly thereafter. Gases as poisons were recognized when Mount Vesuvius went up, when they had the fire in the Cleveland Clinic and the Coconut Grove, and the smog in 1952 that made people in this country, the first episode with smog was a real problem, and Bhopal, when there was an escape inadvertent over in Bhopal, and some 2,000 people succumbed. When it comes to food, ergot which is used to make uterine contractions today, but it's in a lot of different food substances, was recognized as poisonous in 994 AD, arsenic and Spanish oil in 1981. By mid-century, we were seeing in this country a baby boom. Over-the-counter medications had appeared. Individual formulation of tablets and capsules had begun to disappear. By 1960, you didn't have your local pharmacist make any of them. You bought them from Chicago or New Jersey. And that's where we got into the unknown tablets and the imprint codes. Anyway, the Academy of Pediatrics did a survey. They wanted all the pediatricians to join the Academy, so they said to the Academy members, what's your biggest problem? And it was easy. 96% of them were in solo practice, and their biggest problem was when Mrs. Smith called at noontime and said, Sammy or Susie just ate Griffin shoe polish. Because back then, there was nothing on the label. If it had been on the label, it probably would have been erroneous. There were no books written. There were no easy access to get to, and this is what led to the formulation of the first poison center. The Academy and 8 hospitals in the Chicago area agreed to pool their resources. They hired half of a secretary. And every morning, that half a secretary would call the 8 hospitals and see what the kids ate the day before that brought them to the emergency department. The Academy of Pediatrics couldn't have cared less about adults. They just collected the information about the kids. The secretary would then get on the phone and try and find out from the manufacturer if the manufacturer knew what was in there, and then got some people who had some ideas about what to do about it, and put all this information on 5x8 cards. 5x8 cards. A computer had been invented, but this wasn't the usual IBM cards. These were 5x8 printing cards. Over 6 months, she accumulated almost 1,000. The Surgeon General came by and visited the Academy one day and said, that's a good idea. Why don't I mimeograph them? Now, a lot of the audience here has never seen mimeograph, but it's a sloppy duplication process compared to Xerox. Those cards were distributed. Within 2 years, we went from 1 center in Chicago to 700. Over the subsequent years, more people with expertise have looked at the information that initially was on those cards, then transformed to microfiche so nobody could borrow the cards and disturb the system. And then there were 36,000 on microfiche, and now we have 2 million items on CD-ROM and the computer. As I said before, with that 88 million, I'm pretty good on 3 or 4. But think for a minute. Can anybody conceivably remember 88 million? No way. Your memory is nice, it's entertaining, etc., but it's not a way to get to information. It's access to information that's the name of the game today. I'm not a computer expert. When I see what children and grandchildren do in terms of getting to information, and then thinking back 10, 15, 20, 25 years, the change has just been absolutely enormous. Today we've seen, and I won't put the slide up, a tremendous reduction. In the 1960s, poisonings in this country among children killed more than 600 kids a year. Child-resistant container, avoidance, public health measure accounts for 80%, 83% of the subsequent reduction that has gone down from 600 a year to less than 30. A public health measure. On that point, I think I'll probably stop here and turn off the slides if we can. We got to go back to do it and end up with some discussion to the other questions, and you can ask me a question or two about chemicals if you have them, but I think I'd go after the first 2 speakers and get them. Thank you very much.
Hi, I was wondering if somebody could define MRSA MRSA, and if it is a public health concern amongst our children in this community.
So MRSA it's an acronym, and it stands for methicillin-resistant Staph aureus. And Staph aureus is a really common bacteria that lives on a lot of people's skin. Staph aureus has been around for a really long time, and we know it's a bacteria that causes a wide variety of infections, lots of them skin diseases. What we've seen in the past few years is there is what we call an emergence, so we're more frequently isolating types of staph bacteria that are not easily treatable by the usual antibiotics that we use. And so we have fewer tools in which to treat them. And we are seeing this more in the community, and so it's sort of a shift from types of infections that we used to be able to treat with a large variety of antibiotics to the same types of infections, but we're only able to treat them with a few antibiotics. Is it a public health problem for kids? Recurrent staph infections have been a problem for kids for a while. MRSA is a little bit more difficult because we have fewer options to treat them with. And we are now beginning to learn whether or not they are more serious infections or not. They seem to be pretty typical for staph infections themselves. It's just they're more difficult for us to treat because we have fewer tools. So I think it's something that's been there for a while, but it's just harder for us to treat now.
Thank you very much.
Let me put a PS on that. Hospitals and elsewhere want you to sanitize your hands, and that cuts down the spread of that staphylococcus. After you wash your hands, please don't drink the hand sanitizer.
Yeah.
Because it's got 68 to 95% ethyl alcohol, and that can be a bit of a problem.
Yeah.
Hi, sort of along the same veins, there was an article in today's, I believe it's an editorial in today's Seattle Times about XDR-TB in South Africa, which I believe is also a drug-resistant strain of TB. And I'm wondering what, if anything, our county is doing to prepare for that.
Okay, so I'll speak on behalf of my colleague, Masa Narita, who's our disease control officer in the TB program in King County. But when I first came to King County, I had the opportunity to work for a year in the TB program, so I can speak a little bit about it. XDR-TB stands for extensively drug-resistant TB. And throughout the world, including here locally, for many years, we've been monitoring for resistance among all the TB isolates that come from the patients locally. It's very unusual here to have resistance to one or two drugs. So we have a very low level of resistance locally in our community. And we have not seen anything like XDR here. But the reason for that is because the TB organism is very clever, and if the organism is exposed to antibiotics during treatment, but not the way they're supposed to be, but someone takes treatment intermittently or doesn't take it fully or takes partial treatment, the organisms can become resistant because those organisms are selected out for. So if you don't use a full dose of antibiotics and kill the bugs, use a partial dose, a lower dose, the stronger ones that are resistant survive. And so in settings, and particularly in countries where anti-tuberculosis treatment is not closely monitored as it is here, where we have something called directly observed therapy to make sure the patients take their medication, their full course for the full duration, drug resistance can develop. The XDR-TB that's developing in Africa is particularly problematic because it's among many HIV-infected persons, also in whom other diseases is especially severe. So to get to the bottom line and answer your question, what's being done here locally is routine monitoring of every isolate of tuberculosis from every patient to test for drug resistance and directly observe treatment of patients to assure that the treatments are taken as they should be to prevent the emergence of drug resistance.
Over there.
Within the last couple of years, there was an article in the Scientific American based on a computer-simulated outbreak of smallpox in the Portland area, and they looked at isolation in comparison to quarantine. And I wonder if you'd comment on that, looking at the avian flu pandemic potential.
I think you see no comment up here.
I didn't see the article, but I can tell you that for smallpox, again, that was a disease that was very effectively controlled with the tools of isolation and quarantine, particularly isolation, because it's a disease that has a fairly long incubation period, and the patients with smallpox don't spread the disease until after they become visibly ill and very characteristically ill. So that once someone is defined as ill, they can then be quarantined or isolated, prevented from interacting with others before they become contagious. So the smallpox is like SARS, is a disease that's very amenable to being controlled by isolation and quarantine. Influenza, on the other hand, is a disease that can spread before the patient becomes symptomatic, has a very short incubation period. It doubles every 2 to 3 days. Your numbers of cases will double. So it's much more difficult to control through measures like isolation and quarantine. However, when done on a large scale, it clearly can make a huge difference in the numbers of cases. You can't eliminate it like you can with SARS and smallpox, but you can drastically reduce the number of cases if you apply those measures very rigorously.
Over here.
I'm a senior at Blanchette High School, the one that had to close because of the flu. And the school's answer to it was we closed, but we had what they called virtual school, which is the thing where we're supposed to like sign in and do our homework and stuff. And so I was curious from a public health standpoint, how effective do you think that will be, and if it'll get any better, because it wasn't very useful as far as from a student standpoint. None of us found it very helpful, but I was curious.
That's interesting. Well, that's very important feedback. So I'm glad you're well now, and I hope things are better at school. What she's referring to is in the national guidance for responding to a large-scale severe influenza pandemic, closing schools for up to 12 weeks is recommended. And so in order for students to continue to have education during that 12 weeks, things like distance learning have been promoted. In her high school, Blanchette High School, is pilot testing or experimenting with a distance learning tool to allow teachers to give assignments and give homework and possibly have some dialogue interaction over the internet. And your one-day experience maybe didn't go very well, but I think it's a very good thing that you're starting to use this tool and to learn how to make it more useful, because if you couldn't really go to school for 12 weeks, clearly being able to have some communication with teachers and get assignments and so on, I think would be very valuable. We're encouraging all schools to explore that, but only some can afford it.
Thank you very much for
Yes,
coming.
thank you, guys. That was a perfect way to end. That was a perfect way to end.